She only comes off of like New Jersey.
Oh,
Like,
it's
or
right,
something.
yeah.
I'm gonna have a bonfire with the PowerPoint, so I'm just keeping like my notebook and stuff.
That thing's gonna burn high with how many powerful people.
My PowerPoint?
Oh, now you're going to, because we start off with that again next
But
semester.
I have my PowerPoint on the computer, so I don't need to.
No, you don't need to be.
Exactly. So that I can have.
But keep this is good to carry with you for
I'm not
nursing.
burning everything, just
Are you keeping your AP2 class?
I kind of have no choice.
I was gonna say,
Oh,
try
good.
that.
So
If
I
you,
have-
like, if
I
you
have-
back out on that, I'm already like having difficulty with that on the Friday, having different lab persons, and I'm like, get that relativity, you know.
No, she's not doing it.
He promised me she's not doing it.
She didn't do it this semester.
I'm not
she'll do
gonna
it
have
next
this
semester.
the one guy, whatever.
No, you probably have.
I should have the person in front of me, but I know you don't like Friday labs, so now maybe if people drop and I'll move over or something. But then Tuesdays and Wednesdays work.
I think me and you we have the same AP2 class.
I'll put it down.
Think about it next semester, okay?
the
Just
AP1
relax for
class,
now.
I don't care.
All right,
If
so
you need it,
what you're
yeah.
seeing here now, it's breaking down all your smiling
Oh, I'm
lines.
gonna
It's showing
double.
you this picture. 8, 12, 5, 5, 1. For a total of 31 pairs of spinal nerves. So you go, what is this ding? Even last class, ding. Last, you have 12 pairs of cranial, 31 pairs of spinal nerves. So you can see why you don't have that many motor and sensory neurons, but tons of interneurons. So it's kind of showing you why. You're seeing how many of these you have. So you're what? 62, 24, and that's it. So you add it up, that's all you need for sensory motor neurons. Everything else has to be interneurons. So we say the bulk of your nervous system is the neurons. 20%, okay? Why are you giving me that look? Not you. You all give me the look, but she really gives me dirty looks. Not
What are you
you.
talking about?
Back there. She looks at me
I'm
like,
just enjoying my damn cooking.
well, that's kind of what the class enjoy.
Go downstairs and buy one.
Oh, they me.
Huh?
They're so good.
No.
All right, so
I made pie.
this is showing you here, just to give you an idea. So this division here would be the dorsal line. That's a ventral vein. Then it finally becomes the actual nerve nape. This is going down here would be the communicating radii, which will meet cerebral communications, which will meet the sympathetic vein. So I'm just showing you the breakdown of how this runs. In the nerve root of the dairy is this little thing right here. You see the kind of have to do this because nothing works, okay? So I gotta sit here and do this shit crap, which I can't stand sitting down in my lecture. What I want you to realize, see, this is all the dural sleeve. So I was trying to make other guys understand, why would a patient say who has a disc problem or something putting pressure on that nerve, it only feels good if I bring my arm up and do this way. I don't have pain. But if it, exactly. So what's happening at the dural sleeve, as the arm moves, that nerve is trying to slide and it can't. It gets hung up on the dural sleeve from the disc, putting pressure onto the dural. So when they say the disc material is only touching the thecal sac, that's what it means. That's going to cause pain. It doesn't have to touch the nerve because I'm putting pressure there. But if it was a car accident or workers' comp, oh no, that's nothing. So then you have to go testify it in court as an expert witness to explain why it's something. And then of course they keep cross-examining to knock it down, but luckily if you got a good judge, he'll tell them to shut up, I'm satisfied, and it's done. Which is pretty nice when that happens. And I had a judge who was a hanging judge, but what I actually said medically made too much sense. Right. So when the insurance lawyer tried to chop it, he goes, where do you not understand if I said I'm done and I'm satisfied? Sit down, he told me. Because doc, you're done, you're excused. That's so one, because a lot of times you go testify, you're there for 4 hours, understand, like it's a freaking murder trial. It's like, give me a freaking break, will you? Freaking car accidents. Just pay, you cheap bastards. You know? Especially Austin, they were the worst. So I love their commercials, they're so full of shit. Get into the second half and they drop. Okay, so there is what it would look like. And let's go back. And there's the poor guy who lost his body. He woke up with just eyeballs and nerves. But he has feelings, remember that. So here we go. So let's get to the brachial plexus. This picture here. Because I know she's pissed, she wanted to get there, so we're there. So the brachial plexus, now you understand, a plexus means a group, there will be a swelling in the spine, creating a plexus. So it's a group of nerves that are going to come out to control a specific area. The brachial plexus, like its name, controls the brachium or the arm. And that goes from C5 to T1. We mentioned this in lab. Okay, so you already know this. Go to the next page. Go to the page that looks like this. All right, and there's the picture of this thing, a schematic, okay? So years ago, you had to learn the schematic and you had to label the schematic, but we don't do it anymore because it's too much you really don't need to know, okay? As long as you understand the nerve root and the nerve, when it innervates, that's really what counts the way you go like this, okay? Now I'm becoming a neuroanatomist, neurophysiologist, so don't worry about it. So what you're going to deal with is this, and we kind of learned this in the lab, but mainly the nerves that we're going to focus on. And we can see all the ones that are yellow, or like they say in the South, yellow. Are you yellow boy? No. Yellow. That would be anterior. At least something you got it. Right. Wow, I'm glad you could join us. You weren't here the other day, were you? At least you tired. You tired? You were still in the coma shop and you ate too much on Thanksgiving. Yeah, I couldn't eat too much because my temporary crown fell off and I swallowed it. And then my tooth was killing me, so I couldn't eat nothing. So all I could have was liquids to numb it. Right? Then the dentist, they were closed all weekend. And, well, that's not an emergency. We can see you Monday. It's not going to mess it up. Just keep it clean. Oh, all right. Every time you touch it, you want to jump out of your head. Every time you brush it, you rinse your mouth. Something cold there. Yikes. Okay, back to this. So the yellow, you can see what a lot of times when you've taken an anatomy, they would say, look for the end of the plexus. There it is. Well, the end of the plexus is making nerves that are going to do the whole anterior arm. So really what you need to understand is those three nerves would be the musculocutaneous, the median, and the ulnar. Take care of the whole front of my arm. The green ones mean they're back, because they come off that posterior cord. The radial and the axillary taking care of the posterior. So this is all radial down to the knuckles, and my shoulder is the axillary. For armpit, axillary. Okay? So musculocutaneous will be this. Towards my thumb is median, towards my pinky is ulnar, and the whole back from here all the way up to where the triceps end is radial, and the shoulder, which is the deltoid, is all axillary. So if you keep that simple thing in your head, I can't trick you.
Wait a minute, shoulder, axillary.
Oh, we're going to go over this a million times.
Triceps, medial.
No. Yeah, radial's triceps all the way down into your knuckles. On the back of your median is thumb. Pinky. Got it? Muscle. So think of the Popeye muscle. Popeye. That's the musculocutaneous. That's Popeye. He gets that big bicep when he flexes. We're going to go through all the muscles with each nerve. Don't worry about it. I'm just giving you a landmark of if it's probably here, it must be this. You follow what I'm saying to you? It's giving you a reasoning of easy way of keeping it in your head. Or maybe not. I don't know. What works for you? It seemed like it just threw a wrench into the gears. Last couple of classes, they just grasped it right away. I'm just trying to help you grasp something to keep it straight in your head. If it's towards my thumb, it must be medium. Towards my pinky, it must be ulnar. If it's the back of my arm, it's going to be radial. Just keep those three in your head. Shoulder, axillary, brachial, anterior brachium, musculocutaneous. Okay, so that's the big long one. You fell. Were you drinking?
This is my first snow.
Oh, so you're not used to walking in snow?
No, I'm not used to shoveling.
She
and
fell.
Cleaning the car, and I'm so short, and I can't reach the whole winch angles.
And she fell. You need to get a tall boyfriend. Anybody else fall down? Well, nobody likes it, but you're no choice. You're going to get it out of there. You don't get food. Okay, so we go with this picture. Good. I never asked. Well, I know. Sometimes I use that as a picture and label it on the test. Those are your bonus points. These are pictures. If you blow those, oh my God, they come right off this. I wish I had shit like that when I was taking these classes. There's what the real thing would look like. Yeah. All right, so let's look at these first three down in the anterior. The musculocutaneous, the median, and the ulnar. So what you're going to do when they come to you, you'll put the nerve roots here, C5, 6, whatever, and then over here you write the muscles. And that makes it an easy way to remember it. Okay? Got it? Are we good? Good. Okay. So, let's start with this guy. Musculocutaneous. C5, 6, 7. Now remember, we're only talking motor function of the nerve. I don't care about the sensory. You're going to get asked that distribution because it's different. So they're not going to screw you up like that. Just motor. Or motor, depending where you're from. Right? The motor function. Motor. Okay, there we go. Are we good? Now, if you look at different charts, they're going to be different. So I'm saying this to you, okay? So, look at the three muscles and innervates. They're over here. Biceps brachii, coracobrachialis, brachialis. Makes sense. You already knew that. The only thing new is we stuck the Y in there. You already know the compartment, and you already know the muscles. So the only thing new to learn is the nerve's name that's making them work. So when you really break it down, that's not new. The cranial nerves were hard, but this stuff isn't. This is very easy to get down. Right? No? Not back there. You need these? Because you're like squinting. Can you borrow your glasses? You can't see. Here we go with the question. There we go. Let's go.
I'm just trying to figure out how to focus that. So we're putting.
So in that box saying muscles innervated,
Yeah.
you're going to write this, this, and this.
And then
Got it?
spinal segments.
Spinal segments, you're going to write 5, 6, 7. Everybody understand? Do you understand? Yeah. You guys are here? So Rig has that. They understand what they're filling in, right? We're good? We're Gucci?
Oh, no, he didn't.
Oh, yes, he did.
Yes,
Oh, yes, he did.
Yes, he did.
Oh, yes, he did. All right, let's go to this one. That's easy, it's less segment. So let's go to the ulna. The ulna is only C8 and T1. So you can see why, for cardiac symptom, I get inner arm pain because that's T1. Right or left. So usually discomfort in here, either side, rule out this first. Discomfort out here, it's usually musculoskeletal. That's usually the rule of thumb when you look, see, hear a patient's symptom. Okay? So keep that in your little nuggets and happy. So C8, T1 of the nervous, what does it innervate? Well, let's come over here and look. Flexor carpi ulnaris, well, that makes sense. It's on the ulnar side, right? Flexor carpi ulnaris. And one half of flexor digitorum profundus. One half of it.
One half.
One half. So it's picking it up here. So if you ask where that is, come up onto the meaty part of your arm, wiggle your fingers like this, you feel contraction, that's the flexor digitorum profundus. This palmaris longus is here, and the flexor carpi ulnaris is right here. This tendon here, and as soon as I roll off that tendon towards the inside of my wrist, I'm right on the ulnar pulse, because it's right near it. And the nerve would be right near that. So you're going to find the ulnar nerve will run with the ulnar artery. The median nerve likes to run with the brachial artery up here and the radial artery down here. That's where your median nerve runs. Okay? Just to give you insights, in case you get asked that. So we got this. So let's go here now. Median. The whole plexus kind of makes the median. So that's easy to remember, C5 to T1, you can't miss that. Right? That's pretty big news. I know Robert Fernandez. You're going to miss me. You're going to miss that mental guy. You guys are all done with me, you're going to say, oh, it was so much fun. Well, you'll get beat over my fault. You'll like him and so you're not going to get me beat until you get to this. Some of them are mean. I've met with them. They're mean, believe me.
I've heard that
This
it
is your-
radiates from their asshole.
They don't swear, laugh, nothing.
Just
They're like
radiates from
robots.
their soul. They all ended up
Only one's nice. He was on a committee, but she's really nice. We got
with one
good-
out of what, 35?
It's something like that.
I've seen some of the nursing students in the hospital, and the lady that they was with was nice.
Some might have been her. She's nice.
For
All my
Rhode
friends that are
Island,
nurses
for-
do.
Right.
Sign yourself
Yeah.
up for mental health
Yeah,
counseling.
she's
Oh,
right
yeah,
there.
so
Yeah.
Just
She's
sign
on
yourself
her-
up now.
See how we
I
can just
haven't
derail
seen
this
this
class all
dry.
over the place? Doesn't take much.
Sign yourself
Oh,
up.
I
But let's
see
get back to
sexy
this.
and nice.
So, on the median, notice there's a shitload of muscles here, but let me make you learn two. Again, flexor carpi radialis, and the other half of that flexor digitorum profundus. Because we have to have a nerve on the other side to turn it on. So again, where is this flexor carpi radialis? Well, it's right here. And as I flex in and I see it, as soon as I roll my fingers off towards my thumb side, I'm right on the radial pulse. Makes it easy way to find it. So when you're in your nursing classes and you're all nervous and they're watching you, and you're like all over the place to find the pulse, just find that tendon, it's right off of it. Well, if you've been a CNA for a long time, it's not an issue for you. But some people, this is going to be brand new, the first time, other than touching their boyfriend's pulse, it's going to be a stranger's pulse. Okay? So let's get this straight. And I'm just saying, how many other people do you touch? Do you touch strangers?
Yeah.
Unfortunately.
Yeah.
Well, some of you are CNAs, yes, that's right. When they're normal, walking on the street, you just say, oh, you touch a stranger. No. How?
Depends.
See how they lose it? See that they're off?
Depends.
You don't just
Sometimes
touch
it's like, oh,
strangers, do you? No.
I just like that. You like
That's
messing
what
with
I'm
us, then we
looking
gotta
for
mess with
here.
you
But
too.
this class, I don't know, they go.
We gotta mess with you too.
Oh, another thing, which one is the O3 group?
I don't even know.
There's
I'm
O3.
Friday.
Is O3 Thursday?
All right,
or
Friday, Thursday, who's Thursday? That's you guys. Why didn't you let the ratings on? When I asked you
You did?
Where yes.
When did you ask that? You did?
to, 2 weeks ago.
I think
Oh, I
I was
wasn't
in
there.
that.
I swear
was in
you didn't ask
Thursday
that.
class when you asked it.
Thank you.
I think so.
I wasn't in there. when
She,
you asked
no,
that.
you never there.
I was-
I was there that Thursday. That was the fun
That
class.
was the Thursday.
I
she
was.
said.
That was
I
the fun class.
Well, no one did it, so I'm gonna love when administration sees this, that I have no ratings at all on it. No, I got none, I had none.
Where do we go to do it?
What do you mean you
You
have
have to go, you have to go online to my CCRI, my schedule, your schedule, where it says my, and you click on this course, and it opens it up and you rate it. And
Okay.
it takes you, it's like ABCD, ABCD, it take you like 5 seconds. And that's it. So
Is it
you
too
can,
late?
You
or
know,
do it now, do
Do
it
you have to
now.
get
Go do it.
I am, because he got his panties in a bunch.
If it's that counted, half these people won't read it. I don't think they read these things. I think they read it for promotions. But when they asked
So
me,
just
are you going to
post
go
that
apply
one
for
too, or
promotion? I said no. Are you applying for tenure? I said no.
I
They
know.
were like, I said, I don't give a shit. I said, I'm 65. What do I give a shit? You told me out in 2 years, I don't care. So I got them. They don't got me. If I was 45, I'd be worried about it.
Yeah.
But 65, no. Why would I? I'm going to be here forever.
You're cheerleaders.
So you guys make me look, I mean, why would I worry? Too old to worry. So do you understand this now? You got the muscles, you have the nerve roots. All right, let's go to the back again. So we have radial and axillary. Let's do axillary first because it's little. The axillary is 5'6". C5, C6. And what does it innervate? Deltoid and teres minor. So how can I screw you up? Is it true? The axillary nerve innervates the teres major. And right now it's easy to say wrong. Right now it's easy to say wrong. But 2 weeks when you're sitting in that room, all nervous, you're going to be like, ooh, which one? Oh shit. I know it's a teres, but which one? Am I wrong?
No, you are.
They look so good. And I want to show you another way I want to screw this up. And I'm telling you already what I'm going to do, and you just let me do it.
Catch someone screw up on the dumb one.
You mess up the easy ones. How would you get? You make
And I
no
see it,
sense.
I'm like, you dumbass.
Most of
Like,
you
it's the
guys
hard
do
one.
good on the hard questions. The easy questions you miss. Because you know why? You don't even think about, oh, that's point. You don't bother reading them.
No, I.
You know, you got a couple of hours
I just
on
don't think I
finals.
processed it. Thank
You're
God.
not time restricted.
Thank God.
We're in that room for, I don't know, 2.5 hours, so you're not time restricted. You need
How many
time.
questions is this one?
We're the same. I'm making one essay and you guys are going to sound really,
There you go. Well,
you guys didn't allow me.
I was about to say, throw everything in there. Put a bunch of pictures.
I'll try to throw life preservers out and anchor to you while you're floating in the middle of the ocean. So we got that one. That was pretty damn easy, right? Other than that damn way I asked it. All right. Now we go to the radial. Again, the radial, easy to remember. The whole plexus. So median and radial, whole plexus. 5 to T1. There's nothing to think about when it comes to asking nerve roots. Right? These are my way to smile. I always try that. The students that try to keep you quiet, things like, here's how to quiet. You should have taken all the time to graduate college. Right?
Is that all quiet down?
No, you'll stay where you are. You better not change. You're just perfect the way you are.
I
Don't
gotta
change.
quiet down a little.
Little, but you will when the time comes. All right. Now look at the back of the arm. So all the triceps, the brachioradialis, and then in the forearm we'll go with just extensor carpi radialis. Don't worry about longus, but extensor carpi radialis, extensor carpi ulnaris. Just write down what you see in red. If it's not red, don't write it down. So just write down what you see in red. Then we're going to show you how I played head games with you on the test. But I'm showing you, so you should understand it's going to happen. It's like telling you, don't jump off that thing because you're going to get hurt. Let me do it anyways, okay? So if I'm telling you I'm going to do it, it's shame on you, not shame on me. I'm telling you. And I'm going to show you how I'm going to do it and how I'm going to easily mess your brains up. And you're not going to look at your notes right now. You're just listen to me. Once you get all down and writing, let me know, and just pay attention to me. I'm going to flip the page so we can help, so you can see after you guys are done writing. Can you like go over the diseases next time? Maybe it makes sense. Just know it's just let it go. So we're all done, Johnny. Let me know. Then you have some see a heavy mean science class like this. I was here, I was yesterday, I'm just doing AP1, I see your names all over, like, shut up. Not by choice.
Oh, I'm so glad I didn't have that lady.
Really?
The freaking Corolla DeVille
You
lady.
remember what's with the hat wearing?
Oh, I don't know, but she, oh.
All right, so don't pay attention. This is just up there, so you. Now you're gonna listen. So here's another one right here. Is it true that the extensive copy on Harris is integrated by the owner? No. Is it true that the extensive copy on Harris is innovated by? Stop passing notes about it. He's a jerk, yes. Is it true that the extensive copy on Harris is innovated by the ulnar nerve? True or false? How many think it's true? How many have no idea? All right. How many think it's false? Well, you know why? How did I screw you up? What messed your head up? What made you jump for ulnar nerve?
Because you said
Hearing the term ulnaris,
Yep.
but nobody paid attention to extensor or flexor. If it's on the extensor surface, the ulnar nerve is nowhere near it. It can't innervate it. It has to be the radial. So it's a false statement. Now let's see how we can get it on the other. Well, write it. Should have wrote it down because we could get asked just like that. How about if we do it on the flexor side? Is it true? Oh, so is it true that flexor radial is innervated by radial? Flexor radial is innervated by radial nerve. It's false. Because this time we had an idea what we're going to hit you with, so we figured out, well, it said flex. So what is an innervated? What is the flexor radial that's innervated? The what? The median, exactly. That's how I trick you. Do you really pay attention to the detail of what you should know, or do you just memorize? If you just memorize, you're probably going to miss it. But if you understand the concept of what's happening, well, it can't go there because it's back here, and this muscle is over here. You understand what I'm showing you? I'm showing you how to think, because that's what you're going to have to do once you get out of these classes. Take what you know and apply it. And I'm trying to show you that. So if I just ask questions where you memorize and vomit it back, you get an A. It doesn't mean you know anything. You memorize it. It doesn't mean you know a damn thing. But if I make you think about the concept of it, and you can figure that out, now you know it, and you're not going to forget it. That's the way I like to teach. Functional, structural anatomy, physiology, so it stays with you. Not just the bullshit stuff. The little tiny shit. What's that going to do for you as a nurse? Nothing. Not a thing. But understanding the conceptual use of it to figure out what's going on in somebody, that's going to help. Okay? That's why I say, it's not always the grade people. Do you know your material? Do you feel confident I know my material? I don't hurt somebody someday. That's how you're going to start studying this stuff as you're going forward. Because you will hurt somebody, you will screw up, and your mistakes, you got to realize you're in careers you can't make a mistake. Because it can't be fixed sometimes. Just keep that in the back of your mind. Know it. That's why I get pissed off when things are wrong sometimes. Not here, but looking you out. Well, I was agreed you can't make a mistake, but they can. That's bullshit. Oops. Yeah, oops. Oops. I opened the wrong side. Oops. Well, you're not going to get away with just oops. I gave him the wrong drug. Oops. I gave the wrong patient the animal. Oops.
That's so true how many surgeries have done
But
per year.
but you
around the
know,
hospital
right.
for long.
But you know. You hear what I'm saying though? That's just negligence. And you should be sued for malpractice.
Leaving stuff in people, like,
Oh,
there's
yeah.
so much stupid frivolous
Look,
things to
you
hear
get
about
what I'm
that.
saying, people? But if you're thorough and you think, Always look at the patient first. What can you do? Get that out of the way. Then work to the next thing. But always look at someone, do they have something that can take their life? And if you look at people that way, you really don't screw up. You're overprotective, which is better than me. And rather run a test and let it come back negative, than not run it and I was wrong. Yes. And I tell patients that. Let me be safe than sorry. You're right where I go, then go down the street. So now let's look at some of the things that can go wrong with this thing and cause a problem. We're going to call this AP versus hand of the benediction.
Benediction, isn't that something from church?
Yes, that's why we're not going to keep that. But why do you think they would call it that?
I really wonder.
Well, because what's all the priest stands? Yeah, all right, stands like this, all right. That's all the rabbis say, well, whatever.
That's how they stand.
That's how they stand.
You never pay attention to that.
Do you ever think of what's happening while the hand is like that? Well, here we're looking for median nerve damage, which would be carpal tunnel syndrome. Why would the hand reading this claim to use this terminology? Well, because when they drove the spike in to put him on the cross, they blew right through the carpal bones and they blew right through and severed the median nerve. And the hand went into this position because these fingers can no longer do this. That's why. But I'd rather call it ape hand because an ape cannot oppose his thumb. That's what separates me from me. So your boyfriend can't oppose his thumb, then he's an ape. What can I tell you? Oh, he acts like an ape. Well, he's an ape. What do you think of that? No comment. Because I knew it would be good. That's why I was like,
Just gonna keep it to myself.
okay. We'll let it keep it to this. So what happens then in carpal tunnel is that the median nerve is being crushed between the flexor retinaculum and the carpal bones because the tunnel's flattening. And this is a common trait to see, especially in secretaries, because they're always typing on a keyboard. Repetitive trauma. Repetitive use injuries create a lot of trauma. They're the number 2 people on the workers' comp. People that use their hands a lot. Hairdressers, physical therapists, chiropractors, massage therapists, dentists, hygienists, people who work now in the blue collar industry, mechanics.
My dad had a car.
Well, it depends what the architect's doing. Depending on what type you're on.
My teacher actually got it.
And if, well, besides, no, whatever white collars, but in the blue collar industry, you can be mechanics, electricians, plumbers, carpenters, anybody who's constantly gripping. So what happens is, not everybody do this to themselves in the class right now. While you're sitting there going over this long favorites test, you're going to get in here and put your arm up like this, shoulder level, and compress them together. Everybody do it. And I'm going to tell you when to stop. Mind your wings, do it. Do it. Or you have it. Don't you have it? Yeah, don't do it then. So do it and push together. And I'm going to time you, and then you tell me if you're getting any kind of anything coming out. Other than fear pressure, no, or words, I'm telling you, no. You got 30 more seconds.
This feels kind of dumb what you're saying.
Well, it does. You all kind of going to take a picture of the whole class and post it. You can make it up. Come on, 15 more seconds. You cheated. You moved your hands. She had to scratch her head. Of course, I got itchy at the right time. All right, put them down. Did anybody feel anything? Anybody feel any tingliness in their fingers? Especially these. You can't remember?
I didn't say that.
Oh, you can't remember. Now, if she would have done it, she would have suffered. So what happens is when you go into this posture, you're closing the tunnel down more. If the tunnel's normal, it doesn't compress the nerve. If someone's getting the symptom, compresses the nerve. Okay? So how do you fix it? Is extension. Now, not everybody needs surgery to fix these. I fixed many of them. So I'm going to need someone to help me. You're going to hold her arm like this. I want No,
Doesn't
not
have
both
carpal
feet.
tunnel, does it
It
anything?
should be knee, but what it's doing, it's opening the carpal tunnel. Then when you're done, you take it this way, and you press this way, you press the tunnel, so you arch it.
Oh, I can feel that.
And that's what you do to help carpal tunnel. And you use therapy, ultrasound, muscle stim, whatever you like to use on them. And you do this for about 4 to 6 visits. And put them in a brace. Usually the patient and put them on ibuprofen and stuff, or whatever they can take. And the patient will tell you about being when we get to the month, I'm getting better. I can grip better, and I can sleep at night without pain waking me up in numbness. Now, if it's not responding, I send them to a hand surgeon. Sometimes they'll give a steroid injection right into the carpal tunnel and keep the therapy going. If it doesn't respond, then they come. They'll do an EMG, see if there is significant nerve damage, cut the flexor vernaculum, and the symptoms will go away. If you get the pressure off the nerve, the symptoms will go away. If you're doing these careers where you're constantly gripping and using, constantly take your hand, put your arm above the head, and extend it as much as you can. Your fingers open, extend it over your head. You stretch and open everything up. Do that repetitively at least every 20 to 30 minutes, which you're going to tell secretaries, especially that are getting symptoms, to prevent the carpal tunnel. So extension will prevent it, flexion will create it. So it's called Phelan's test, plus Tinel's, plus the EMG studies and everything else to confirm it. MRI of the carpal tunnel if you want. But the nerve is getting trapped. And the symptom the patient will feel is mid-forearm, all the way down, especially thumb and these 2 fingers. Because half your ring finger is also innervated by that nerve. That's why when you move the fingers around, this one feels weird to move it by itself. It like usually makes this one move or something else. Because the 2 nerves fire at the same time as you're trying to pull it in. So you always pull your pinky with it. The only fires with the median to make it lock in. So another thing you do is can they oppose? So put your thumb to your fingers like this and hold it real tight. And you try to pull it apart. And you do it bilateral on both hands. If one hand is really weak, as an indicator, they'll tell you, I can't grip things like I used to. My grip's getting weaker. And that's early signs of carpal tunnel without the other symptoms.
What if you use your hands a lot one day and then the next day you wake up and in the morning you're like,
Oh, that's just overuse.
alright,
That's
thank
just
God.
overuse of muscle.
Okay.
I thought I was
No,
getting
it's not a one-time
What is-
event. It's a multiple time event, not a one-time event. Multiple time over years.
What if if you grab something at like one point in your hand just kind of like freezes in that position and like this muscle goes like
That
kind
might
of
be
in.
the neck creating it.
Because that happens to me
It
all the
might
time.
be an ulnar nerve issue from the spine.
That
You
happens
get into a
to me.
certain posture, it happens.
Yeah, and it hurts.
And it
big.
hurts. So that's that guy. So the next one then is
I don't think I've ever seen a claw hand.
ulnar nerve, claw hand.
Never seen it.
No, it's not coming.
I would say, how do you, because I've never seen it.
And usually these 2 fingers get locked into like a flexed, extended posture. So the hand looks like a claw.
That, yeah, how could that be?
So you just get asked on a test, claw hand is what? A, radial, B, ulnar, C. You understand? It's that simple. So this is usually a problem. You can be here, the tunnel of the or around the medial upper condyle. A lot of times you got to translocate the ulnar nerve, take it and move it here. So the neurosurgeon will go in and grab it and they slide it over to the front of the elbow. So, because every time you flex, it's like, oh, I can't do it. That's your funny bone. Bang the ulnar nerve. Next. Fist drop. That's radial nerve damage because I can't extend my wrist. There's no strength. Now, radial nerve would usually be a problem up in here. Usually a disc, C5, 6, pushing on the nerve is pretty significant. Okay, so the person would have weakness in anything that the radial nerve is innervating, there would be weakness. And that would be wrist drop. You put pressure on it, it falls. So we use Wechsler's scale, out of 5. 0 means there's no movement. 1 you can't even resist against gravity. 2, anything touches it, it drops. 3, 4, 5 is in your ranges where it takes some pressure to make. 5 is like you can't break the rule. So 5 out of 5 is what you're looking for in people for muscle strength and grip strength. Okay, so those are the things you would do to figure this out. There's another one you already found we call Erb's palsy. That's when the whole plexus gets damaged. That's common at birth. Not common, Erb's, E-R-B-S. And what happens is when they put the forceps on the baby's head to yank it, the shoulder gets hung up on mom's pelvis and they traction out the plexus. And the baby's arm stays like this. And it can't move. Now, if it's just contused, over time it'll work. If it tore, then it doesn't work. You have to surgically repair it. Okay, so it's also like head tip before when you were like this, so you put the money in there and they put it in their pocket and they stitch it down.
I didn't hear what was being mentioned.
What nerves?
Not this
Herbs?
one. Yeah.
The whole plexus, C5 to T1. Because as I'm tractioning you out with the forceps on the head, pulling the baby out, the shoulder gets caught and they yank anyways to get it out, and it tractions out. It's a traction injury to the plexus. Okay? So there's the brachial plexus. These are the things you can see. It's not common to see, like, the axillary. It's not a common nerve to hang out. That's usually a entrapment syndrome in the neck or something to do with that. Very rarely it's weak. Just there's more than one muscle doing this motion. Supraspinatus in there going into supraspinous nerve innervating supraspinatus and the back of the dorsal scapula innervating rhomboids and all that traps is innervating the body. Which one? You guys know that. Cranial nerve innervates the traps. 10, 11, 12. Which one?
11.
There you go, 11. Which 12 innervating? I just showed you the tongue.
Yeah.
Yeah. 10 is vagus. 10 does everything. That's when you should get all weight in your head right away, the vagus. Okay. Look at the powder sympathetic nerves. Which four? Just give me the numbers. Don't give me the names.
7.
And we know 10.
2.
No, not 2.
3.
3, 7, 9, 10. How many know that right now? How many? Not that, but you know it. It makes sense to you right now when I say that. Good. So by next week at this time, you know what you're back in your hand. Because if you don't get that break, if you don't get this down and that down, that's a good part of your questions on the test. Because you're going to make a lot of questions from it. Understand, especially that cranial nerve stuff. Know them. You're going to use them the rest of your life, people. When you look at a patient's face, you can tell right off looking at it. In Bell's palsy, I did a webinar quiz today, and it was Bell's palsy. 34-year-old female, had the flu, had all these weird symptoms after, going into occipital pain, this and that, and kept talking about her face drooping, she couldn't blink her eye, couldn't close it. I said, it's gotta be false. Could it be a tumor? Yeah, but most obvious criminal was false palsy. And her, they had a decompression surgery to relieve the pressure off the nerve, to make those symptoms go away. All right, so let's go down into the lumbosacral plexus, which is going to take care of the leg. So you turn your page. All right. There's obturator, there's femoral. So obturator goes to the medial thigh, femoral does the anterior thigh. Okay, so this goes to the front, and this one goes inside. Sometimes you might have a patient come in, and they'll say, I get my tea leaf, like things like ants walking up and down the outside of their thighs. And if you look at them, they might have that muffin top built. Well, what it means is their pants are too tight, and it's compressing the lateral femorocutaneous nerve on both sides. And you just tell them, well, it'll lose weight or buy bigger pants, and you'll feel better. I mean, they do. Or you can hear, I got like significant discomfort, like right in here. I got like a tingliness, like right near my groin. No, it's clean, okay? Well, it's the genital femoral nerve being trapped, and that's being trapped because probably your underwear is too tight around your thighs. Not a thigh, okay? But, so these weird symptoms can come just by clothing to be fashionable. Well, I'm not buying a size bigger because I'm not that big. Go buy clothes and I gotta buy pants one size up. Most of the time, I'm not buying them. I know what my size is. It's gotta be marked wrong. Well, the way they style and cut clothes, they're always gonna buy by how it fits than more by size. Because they're not all size. It's like you buy 3 slacks and they're 3 different colors, right? All 3 don't fit the same. Even though they're the same brand, they don't. Fabrics run different. The way they would cut the fabric may not be the same. So you gotta try each one out. There's nothing worse than you go home and it don't fit and you gotta bring it back. That's the worst thing in the world. That's what I hate about online shopping. It don't fit, I gotta return the stupid thing or ship it back. It's a pain in the ass. So those are just weird nerves that can be in the picture because of just habit. But the obturator and femoral kind of important. And rarely do they get involved with this, because this is more common in 5S1. So L4 can be involved, but it's not a common entity to get a femoral nerve or obturator nerve hung up on a disc. So that's the guys that are in the video. So the whole back, the whole poster that's shown here in the picture, see femoral. Femoral's really big. A lot. Then we get to the posterior aspect, you have the sciatic, which creates the common. Now in your notes it says, in your handout it says common peroneal. This cross off peroneal will make it common fibula, because it used to be known as that, the nerve. When you go to the back, see the bottom, see, it's common, we call it, it's no more peroneal, it's common. Fibula. They changed the name. Why to sell things? That's why. All right. So in other words, the sciatic nerve creates these other 2. Creates the common fibula and the tibia. They're just 2 branches that run. So when you get around posterior knee, it branches. Remember that on the model? It branches. And one going straight down, digging behind the gastrocs was tibial, and the one that floats over the side was the common fibula because it crosses over the fibular bone. Why it was called peroneal before? Those are the peroneal muscles that are on the lateral thigh where it would go. But we can't do that. It makes no sense. So it's changed. So let's look at these now, just the way we did the others, and figure out what they interviewed. Now you can see why the piriformis irritates that nerve so much. It runs right through it, right? So when this thing spasms out, it presses right against it. And it is really. So let's look at femoral and obturator. So the femoral nerve, or femoral and obturator are both L2 to L4. They're both the same signals. One's the anterior, one's posterior. They're different divisions, but same segments, okay? L2, L4. So we said the femoral is going to come here. So it's innervating my anterior compartment. What were the muscles there? Sartorius and the quadriceps. What makes up the quadriceps?
It's half of the pectineus.
No, forget that. Don't worry about that half shit.
I don't gotta worry about the half on this?
No.
Alright.
No, I'm not going to cross you up like that. Let's take this one. It's going to go with this one. Don't worry
Put
about
the
it.
pectineus with the obturator?
Yes.
Okay.
Pectineus would be with obturator. But right here, 1, 2, 3, 4, 5 are going to go with the femoral. Okay? When you get to obturator pectineus, gracilis, and all this abductor shit, just write adductor femoris down. You don't have to write adductor brevis longus magnus. Just write adductor femoris, because that's how we learn. Alright, so what I'm saying to you, just write adductor femoris, the operator, adductor femoris, pectineus, gracilis. Just right here, when you come abductor femoris, and you get to the operator. So write adductor femoris, and then write down pectineus and gracilis. Because we didn't learn these three individual ones, so we grouped it together, called the adductor femoris. It will appear that way in the text. Okay? To make it easy for you. Okay? Make sense? Make sense, everybody? So in other words, to bring my leg in, that's the obturator nerve. To extend my knee across my leg, that's femoral nerve. So think of what it does. What does the compartment do? So if a person is having trouble, weakness extending their knee, they probably have femoral nerve issue. Can't adduct the leg well on one side, probably have obturator nerve issue. Just think about it. You already know the muscles, you already know the compartment. All you do is put the plug in there now to make it work. The only thing new and added is femoral and obturator. Everything else you already know. You were tested on it. You know it. Well, you didn't know it a month ago, but now we forget it. Well, yeah, we did know it. You know, so you get what I'm saying? All right, so now let's go to the sciatic. Well, the posterior thigh is innervated by sciatic. So what muscle group is in the posterior thigh? The hamstrings. What are they? What's the hamstrings? Biceps femoris, semitendinosus, semimembranosus. Now, what is the roots of the sciatic nerve? L4 to S3. Don't have to break them down for the tibia or the fibular nerve. Just do it for the sciatic nerve. So, L4 to S3. That's the innervation. In other words, these are already before. So the biceps femoris and semitendinosus, semimembranosus. That's it. The one's in red. Posterior thigh. So if you flex the knee, there you go. So if I can't flex my knee, there's the issue. Now, let's go to the posterior calf, the posterior leg, right? That's going to be tibial, gastrocs, and gastrocnemius, and soleus. The calf, right? So, what would you see that would be affected? What motion would be difficult to do? Dorsiflex or plantar flex? What am I doing right now? I'm plantar flexing. They won't be able to stand on their toes. So someone with significant sciatic issue, you watch them walk, okay, get on your toes and walk. They're like, they can't. So you know what division is being affected now. Now if we go into the common fibula, it's going to be tibialis anterior extensor digitorum 1. Yeah, there's other ones on this. Maybe you learned the ones you learned, the red ones. So they wouldn't be able to do what? Dorsiflex the foot. So if this person has significant issue with this, you'd hear them walk like this. They have foot muscles that are not strong enough to hold the foot up as they walk. And you hear the foot slam with each step. Because they have damage to that nerve. So if you're going to ask the question like that, the person has difficulty to stand on their toes, what nerve is most likely affected? Tibial. Person has difficulty flexing the knee, sciatic. Or she flexing the foot, common fibula. Can't cross their leg. That's the sartorius, probably the femoral. C, understand? Yes.
So what do you want us to write for the, for sciatic nerve in that box? We want us to write
Maybe we know what you do.
for,
Muscles innervated?
yeah,
Posterior thigh, which is the hamstrings. That would be the biceps femoris, semi-membranosus and tendinosus. That's true sciatic distribution. Then when you cross the knee, it changes. I'm making it easy for you. Got it? You got that now? You understand? It'll be the branches when it gets below the knee. Above the knee is sciatic. Now, the other time you'd get that specific on diagnosing with branches one, you'd have to do an EMG. But someone paying weighing on the posterior thigh, wrapping around this way, you're going to call it sciatic. You're going to die sciatic neuralgia due to, piriformis spasm from the buttock region. It'd be something, you're not going to just say, no, you can't. You got to do an EMG to delineate which one is the actual segment. Understand? See how easy? So now you know the brachial plexus, the sacral plexus, and the cranial nerves. The only thing left to do on Monday is going to be the autonomic system. We've got the Monday. And then put any questions you have together on the review sheet after we finish autonomic. Autonomic will take only about a half hour. We'll go into, like, if you're stuck with something, bring it up. Let's get it. Now see that graph I drew on the board? Make sure you know that. So let's summarize, see how much you remember of that. When I'm going into depolarization, this is repolarized and depolarized, hyperpolarized, right? So negative 55 is what? Resting membrane, right? And 70 is resting membrane. What's 55? Threshold. Okay. At 30, you're at maximal threshold, then you go back down. At negative 90, you're at hyperpolarization, you can't fire. When we go from here to there, is that a positive or negative feedback? Positive. When we come back down this way, it's a negative. What elements going in? Sodium. So whenever sodium and calcium move, that's excitatory. Whenever potassium and chlorine move, that's inhibitory to the nerve. Remember that. And just remember those four things you know a lot. So whenever you're moving potassium or chlorine, I'm inhibiting it. But when I move sodium or calcium, I'm firing. Okay? Just keep that in your mind. And that's what we did. So if you understand this graph and you have questions about it, you're fine. That's the physiology. The other part was the end part. The different transmitters. Know what each transmitter does. That's what I'm going to ask you. Is it inhibitory or excitatory? So that's all that's abbreviated all out, written out on your study guide. Those are just each neurotransmitter. Just look them up in your notes and that's what it is. Just know what they do. GABA we know is inhibitory. Acetylcholine, no. But when we get to the autonomic, acetylcholine is inhibitory to the sympathetic system, but excitatory to the parasympathetic system. And the norepinephrine is the excitatory in the sympathetic system. Okay, so that's the only system left to do. And it's not, the way we're going to do it is not very different. I'm not going to go into all the different receptors, alpha 1, 2, 3, school it. But alpha receptors are acetylcholine, beta receptors are norepinephrine. It's as simple as that. Okay? So I put you on a beta blocker on stopping adrenaline from stimulating your heart or your blood vessels, okay? That's it. So in lab this week, the lab this week is real easy. It's just doing reflexes. You're going to be testing